Ko Waiao, no America toko whānau, ko Sandia Te Monga, ko Rio Grande Te Awa, ke kirikiri roa aho e noho ana. Tēnā koto, tēnā koto, tēnā koto katoa, and a warm Pacific greetings to you all. I have worked with primarily Kaupapa Maori community organizations to develop and implement health and social service interventions for the past 10 years. A key partner of mine is the Roa Awa Awa Komatua Charitable Trust, who I've worked with for more than 10 years, as well as Te Runanga o Kirikiriroa. I also have partnered with another 14 different Kaupapa Maori community service providers. And in doing this research, working with these community providers recognizes the importance of research, particularly to address health issues, health equity issues for their communities. And there's a recognition of the importance of research for these projects, for these issues, if it's done in the right way. And so what I want to do today is share with some of the key barriers and facilitators of translating research into practice from a community perspective. So basically looking at from primary research as well as some systematic literature that identifies these barriers and facilitators. Introduce two models that guide implementation research into practice, emphasizing some of these key aspects of co-design. And then going forward, my pathway going forward of the importance of developing an implementation network. So if I start with challenges and barriers, these have been mentioned before by a number of the speakers already, so I won't spend too much time on this. But certainly having the resources and workforce capacity becomes really important. As Matere mentioned, providers are very busy and don't have enough resources to do everything. So this becomes a challenge for putting research into practice. It might be the best idea, but if we don't have the resources, that's a big constraint, particularly in our rural providers. Other key aspects, a lack of input from community health providers is a big component. Marianne mentioned the importance of co-design, but this is something that community providers I've worked with emphasize, is they know their communities very well, and they can see research that might have beneficial aspects somewhere else, but it doesn't fit, it's not compatible with their systems, their processes, their culture. So that becomes a barrier to trying to implement research into practice, and certainly a larger distrust of the system becomes important. Our colonial history, racism, and that lead to these inequities. So all of these become barriers for implementing novel research into practice. And there are some facilitators of implementing research into practice. Number one on my list is the importance of program adaptability. And by this, what I mean is that when we take an intervention and we try to bring it to another community organization, they want to make it their own. They want to adapt it. They want to own it. And so being able to adapt, to change its, particularly its form. In implementation science, we talk about form and function. Functionality is the key that makes it work. Key components that need to be implemented, but the form is something that makes it fit better. And so being able to adapt, particularly the form, is important. Now, other aspects that are facilitators is program structure and creator experiences. So the people who've developed this, if we can somehow share their experiences of what works and what doesn't, and provide this structure or guide, that really helps community organizations. They want to learn from others that have gone before, what works and what doesn't. And we found that in our experiences, in our research, that this is really a beneficial component, is learning from others and having that sharing. Strong provider relationships. Patient-provider relationships is important as well, as a key facilitator. Making sure there's cultural safety in the organization, so that the community organization that's implementing it has a big say in whether the communities themselves will adopt the intervention. And then finally, having good leadership and willingness to innovate. Sunny talked about the need for innovation, and this is certainly a key aspect of trying new things out and being willing to fail. Now, I want to move to two models describing implementation research. The consolidated framework for implementation research was developed by Dan Schroeder and colleagues and identifies 5 key elements. Now, much of our research focus tends to be on the characteristics of the intervention. Is it effective? Does it work? Does it have causation? Does it have relative and economic advantage over what already exists? So a lot of focus goes on that, but in implementation, there's a lot of other things that matter. And so we need to really focus on these. The inner setting is the organizational support, the workforce capacity that needs to come into play that others have mentioned, such as Diana, developing workforce capacity. The outer setting, the political will, the resources, the willingness to try new things, that becomes really important in terms of being able to get support, the resources as well in order to implement the intervention. Individuals involved in their capabilities. Do we have enough clinical skills in particular communities, as I mentioned, particularly for rural communities? And the process by which the implementation happens, the planning, the execution, the evaluation becomes important. And these are important research elements that need to be examined as well. There's lots of research aspects of implementation that we don't understand well. And this last point about process is something that my colleagues and I have really focused on, is in developing what we call the He Pikinga Waiora implementation framework. And it's a framework that emphasizes a Maori lens on implementation processes, that really emphasizes how we do things, not so much on what we do. The what's important, obviously, it needs to work, but how we implement and how we do this through a co-design and participatory framework is really important. And this model describes the 5 key elements of our framework, but it starts and centers with Mātauranga Māori, that the principles, the way that we work, that it has to be Māori, by Māori, for Māori, and that it has to emphasize Māori knowledge. It should be done through a participatory co-design framework that enables to engage the communities, the community organizations, and centers their cultural perspectives, particularly in defining what problems are important and what solutions exist. And this was something that Marianne mentioned, the idea of working with a practice-based network to identify what are important problems. And this is the idea of the He Pikinga Waiora implementation framework. It also emphasizes a holistic system perspective, as well as working directly with end users. So end users are the people who are going to implement and fund this. So it means integrating policymakers, DHB representatives, ministry, as well as our community organizations early in the process, so they have a say in what gets done. So we can develop the best research intervention, and yet people don't implement it because it doesn't fit their community, it doesn't work, it doesn't address their needs, they don't have ownership, all of these elements. So this process becomes very important. So moving forward, what pathway that I think is really important is the need to develop an implementation network. And Rod talked about this earlier, about the need for a structure. And this is the type of structure that I think is really important to bring our community providers and our primary care practices into the implementation process early. The typical model is that we have researchers develop, then we get funding support through policymakers, and then we expect the community providers and the primary care practices to actually implement it. What we need, they need more voice early on in the process that needs to be co-designed through a participatory or partnership model following the te. There needs to be multi-way communication and decision-making and a health equity focus. So this network really emphasizes health equity and provides this infrastructure that enables us to move from research into practice. I have an example in action of this. I'm a part of a research team, the Komato Mana Motohake Poi project, funded by the Aging Well National Science Challenge. led by the Ro'au'au Komatua Charitable Trust, we've developed the Kotahitanga Implementation and Research Network, where we work with 10 other Kaupapa Māori Komatua service providers. We developed a peer support model that we wanted to share with other providers and implement it and trial it out, test it out, excuse me. And we did this through a participatory approach. Even though the Ro'au'au had led the project, we still worked in partnership and co-design with the other providers to make sure that the model worked for them and that it would fit in their community. So this co-design participatory approach was very useful. And it also became an avenue for sharing with each other, learning that it provided a chance to figure out how to do things more efficiently, and not just about our project, but about other issues, particularly around COVID. Now, this network is a great idea. It's worked really well, but it's also based in one program. And what I want to pursue going forward, and Healthier Lives has supported this, is developing an implementation network that is beyond a single research program or single research. So it will create a structure working with Pacifica and Māori leadership to help develop a provider-based or community provider-based network, linking researchers, policymakers, and community providers, ensuring that community providers have a voice in how research is implemented and what research is implemented. Tēnā koutou, tēnā koutou, tēnā koutou.